I got a little story I want to tell you about hearing loss, dementia, and smoking, and what they all have to do with each other. I know that may seem like an odd combination, but if you really look at the importance of risk reduction data, you will see that it's completely applicable to today's discussions about hearing loss and cognitive decline and dementia. Do we or don't we tell patients? You know, some people think that the connections of hearing loss and cognitive decline are brand new, right? They think that Dr. Lin and Johns Hopkins were the first to present this data that linked degree of hearing loss with potential risk of developing cognitive decline, when in fact, the correlation data dates back 50 years. It was highlighted, published again in the 80s, only to be resurrected and be highlighted by the great work of Dr. Lin and his colleagues, including not only the observational data of increased rates of hearing loss and decline, but also looking at rates of global cerebral atrophy in people with hearing loss, which is a hallmark feature of people with cognitive decline. So let's take a minute to find out why science truly does matter when it comes to the connections of hearing loss, cognitive decline, and dementia. Well, most know the data at this point, but allow me to reiterate. Give me a second here. A patient's hearing loss level or degree is significantly correlated to their potential risk of developing cognitive decline and dementia. The two most important words in that statement are significant and correlated. When the word significant is used in science, it indicates that the data found essentially could not have happened by accident, okay? Number two, the word correlated. That implies that the two are somehow linked to each other, and the data is compelling as to indicate there is a significant trend of the association between having hearing loss and potentially developing cognitive decline and dementia. Perhaps a great example of this risk is, well, smoking. And I'm going to quote here from the CDC. Smoking is the #1 risk factor for lung cancer. The more years a person smokes and the more cigarettes smoked each day, the more the risk goes up. Therefore, smoking significantly increases the risk of developing lung cancer. And while I have lost a loved one to lung cancer, that likely was a result of his many years of smoking. My own grandmother died in her 90s after smoking a pack of filterless cigarettes every day for over 50 years, and she never so much as had a cough, pneumonia, or any other issues related to her lungs. Why do I tell you this? Because increased risk is not a promissory note. It is not a guarantee. And we should never look at a case like my grandmother's and somehow argue, well, see, she didn't die of lung cancer, therefore, smoking isn't bad for you. Seems ridiculous, right? As a hearing healthcare professional, it is our responsibility to educate our patients on their increased risks. To not do so is an ethical violation of our commitment to hold the welfare of each patient paramount. For those who regularly see patients, you know it, you see it, you live it every day, working with patients who have hearing loss and struggle with cognitive processing disorders. For those who are incorporating cognitive screenings, you too see it every day, the potential for increased risk of developing cognitive decline. And for those who treat patients, you understand that treating hearing loss is considered by the medical community, including publications in the American Medical Association and The Lancet, two of, if not the most respected scientific journals on the planet, to be the most modifiable factor for preventing cognitive decline and dementia. Again, this is not a promissory note, but it is helping patients reduce their risk. Recall that the rates of dementia are expected to triple in the next 25 years without a single readily accepted and available treatment for every one of those patients. Yet, extending MCI by 1 year, meaning if we can prevent MCI from converting to dementia by 1 year, it would decrease dementia prevalence by 10% by 2050. We are on the front lines of cognitive health and helping to educate our patients on the importance of treating hearing loss and Inclusion of the remaining 11 modifiable factors that help our patients to live their best life, their longest life, and most cognitively intact life is what it means to be a hearing healthcare provider.